Next we have late complication of EVAR, type 1B endoleak. Always stick to the IFU. And this is my Professor Naser Elsaed from the military.
صباح الخير. بسم الله الرحمن الرحيم. Today I would like to talk to you about an important issue. Late type 1B endoleak after EVAR. It's better to stick to the IFU. As you all know, this is a different type of endoleak. We concentrate here on type B here. So usually type B occur maybe due to planning error or technical error. Quickly, I just would like to remind you with the causes, maybe the tortuous iliac or short common iliac, short distal sealing lens, and also large aortic aneurysm sac. So usually undetectable cause, usually because due to progressive of the disease and dilatation of common iliac artery by time. Considering data from the current literature, usually the type 1B endoleak occur about 20% intraoperative, 30% early, I mean within 6 months, about 50% late, more than 6 months. And as you all know, the treatment may be endovascular, hybrid, or surgery, and usually mainly endovascular with extension of the endograft. This is the main and effective treatment. Most results of approved studies show that there is no significant difference in sex, age, or brand of the stent graft were observed between type 1B endoleak and the control group. Patients in the early type B endoleak had significantly more tortuous and short common iliac and short distal sealing lens, and the late endoleak group had significant larger maximum aortic aneurysm sac diameter, short common iliac, and short distal landing zone. Usually treated with extension. The various mechanisms of type 1B endoleak differ depending on the time of onset from the procedure. Careful preoperative consideration of the aortic aneurysm size and common iliac length and tortuosity is essential, and the patient with risky feature should undergo strict postoperative surveillance. Now my case presentation today, this is a chap, 36 years old, has no significant medical or surgical past history. He coming to us with abdominal pain, recurrent abdominal pain. This patient, we done ultrasonic, which show pulsating AAA, and then confirmed by the CT angio. He had a successful EVAR, was done since April 2016. Serial CTA done after 3 and 6 months and was normal. Ongoing follow-up in August 2021, CT show type 1 endoleak from the right side and left side. We did admit the patient and preparing him to manage or to fix this problem, and definitely we thinking first in doing extension. We succeed to get this is the pre-EVAR. It was nice aneurysm with nice landing zone, proximal and distal. We don't have the conventional angio for the immediate intraoperative one, but we could succeed to get, this is the 3 months post-operative. No comment. 6 months later, and as you see, I think there's a shortage of the 2 limbs away from the common iliac bifurcation. This is 4 years when he arrived to us in August 2021, and we found this, and as you see, a bit aneurysmal right common iliac. I just remind you with the IFU, definitely adequate landing zone is important. Usually more than 1 centimeter is okay. Iliac diameter, average 7.720. Oversizing, usually in a healthy iliac, 10% may be enough. In ectatic iliac may extend or increase the oversizing to 15%. Adequate common iliac artery length should be 3 or more centimeter. If shorter than 3, you have to go to land in the external iliac. In case of common iliac artery shorter than, you have to go to the external to make good sealing. This is our CT done on admission. You will recognize leaking, marked leaking, obviously. Right, this is some picture showing the leaking. Here, filling the sac, and this is reconstructive film. So we started to make sure from the diagnosis first, going from the right groin, taking serial picture showing the leak from the right side, taking the measurement of the right common iliac. The stent was about 2 centimeter. So this is the measurement for the right limb. Actually, I think the previous device is quite different. Another company, not our stent we used. So we manipulate this by using 2 stents. Our main target to get down to the common iliac. So just quickly, 1 minute. Right, here we continue the procedure until we finished, but unfortunately, we should go from above to put the second extension limb on the right, then complete on the left side. As usual, nothing. This is the measurement of the left extension limb. Right, seeking for time. Sorry. Here it is. So my conclusion, actually, an extensive sealing lens may be protective against type 1B endoleak, especially when the size of the aortic aneurysm sac is large, or when common iliac has risky feature, including large diameter or short lens. So we have to pay some attention to the distal rather than we are concentrating mainly on the proximal neck. Thank you very much.